for 3 years to the day, it has to be over 3 years, then they count as a new patient. That also means, though, that if you share a practice, someone has seen me 2 years ago, but they come back and see another doctor in my office who's also an ND, and we're in a group practice, that is not a new patient, even though it's a new patient to that doctor. If it's been greater than 3 years, they get to count them as a new patient as well. So it's but if we have our nurse practitioner, for example, in our practice, someone's been gone for 2 years, I haven't seen them, but they come to see the nurse practitioner. She's a different specialty, a different license type, so they would count as a new patient for her. So it's by specialty and length of time. Unlike return patients or established patients, where you only have to have 2 of the 3 components, with a new patient, you can only code at the highest level of CPT that all 3 elements meet or exceed. So if you only get to a 203 in complexity, even if you have a 205 in history and a 205 in physical exam, because you only hit the 203 in complexity, that's as high a level as you can bill. So it's important to understand what builds these codes and what will get you to that higher level code if it's appropriate. If they come in, it's a new patient, and they only have a cold, like our previous example, cold and allergies, you're going to be hard-pressed to make that more complicated than it is. They're probably only a 203. It's going to be hard to make it more complicated and more complex, and remember, it's unfair, but that's where they weight it, is with the complexity. So how I often think about this is, even though we like to think about it linearly with history, physical, medical decision making, I will often turn it around a little bit. Think about your complexity, because that's what gets weighted the most, and let that help guide what else you're going to do. No one anywhere said that we have to spend 60 minutes with every new patient or 90 minutes with every new patient. If they're an acute illness, I may spend an hour with them because I do want to get their diet history, but they probably have other things going on besides just this acute cold today. So I'm going to have more codes. It's going to become more complex. But if I occasionally have that person, new patient, all they have is a cold, they're like, please, just tell me it's not strep throat, I may only have that half-hour new visit. Again, having some of the shorter, more not concrete, but shorter, concise visits, especially if you do a lot of insurance billing, those short little visits that are 99203s, they can make up for those more complex visits where you might not get reimbursed for the extra time that you spent with someone. You do the best you can, but insurance is not built for all the time that we necessarily spend counseling or helping people. So I like mixing it up. That's my personal take on how to make this work when you do a heavy insurance-based practice. Someone asks, what if a chronic cold that recurs over and over? You probably can turn that into a slightly more complex visit, because there's probably going to be some other codes mixed in there. It's not just the acute URI. There's probably some other pieces in there that are going to make it more complex, more ICD-9 codes primarily. And then someone asks, regarding a new patient definition, how is a group practice determined? By location of clinic or tax ID number? That's a really good question. Even though it should